You guys are great mentors for us younger spine surgeons, and it's a great honor to be here. So today I'll be talking about optimizing Kambin's triangle surgery. Here are my disclosures. So just in terms of objectives, I have 10 minutes, so I'm going to talk pretty fast. Talking about defining what Kambin's triangle is, and I think we should actually call it Kambin's prism because it's a three-dimensional structure. And then we'll talk about adjuncts to make operating in Kambin's triangle or prism safer. Radiation reduction, we've talked a lot about that today. Implant choice, and we're going to hopefully introduce this concept of patient-specific TLIFs. So if you look at Kambin's prism, I think Mike Wang's group has done a really good job talking about this. We've looked at this kind of from a systematic way. If you look in terms of the diameter of Kambin's triangle, you see that as you go more caudally in the spine, it'll actually get bigger. And then as our endoscopy folks, like Dr. Hofstetter will tell you, if you take off that SAP and you do a foraminoplasty, you can actually increase that diameter by about 2 times. So it can really improve your ability to do surgery in that area. We also showed that if you have pathology, and this is really important, a lot of these anatomical studies are done on cadavers, but they're not pathology, which we as surgeons deal with all the time. So if you have a disc herniation or you have a spondylolisthesis, Kambin's triangle actually will decrease quite significantly. And so that's something that you have to take care of. So this is the way I used to do Kambin's triangle surgeries, and this is the way I was trained by John Chi at the Brigham. We used to take 2 C-arms, one in the lateral, one in the AP. It used to take about half an hour just to set up, right? It used to be very painful. People didn't like me, the residents didn't like me, the radiology technicians didn't like me. And, I'm going to talk a little bit about awake surgery at the end of this talk. There's no way you're going to do awake surgery if it's going to take you half an hour just to set up your C-arms. Then we got introduced to this concept of optical and fluoroscopy navigation. And this is something that we helped found here at Duke. And here the fiducials go on the C-arm, and then you have the instrument tracker. And I'll show some of the stuff later on in the lab and in clinic and cases. It really improved our ability to get into Kambin's triangle. And for the endoscopists, they'll tell you the hardest part of doing endoscopy is getting into Kambin's triangle, right? And this has made it much, much easier. So now I don't need to use 2 C-arms. And we actually proved in this paper that we could get into Kambin's triangle so quickly, quicker than we had when we had 2 C-arms. And so this allows me to do this much more reproducibly, much safer. I'm in a teaching institution. I can now allow residents to learn how to do this. Before, when you just had lateral surgery, lateral x-rays or AP x-rays, you really didn't know where the residents and the fellows were. Now I can see in both planes where they are in real time. So how about the implants? I think we talked a little bit about this today, about, what the implant of choice will be. Some people have used this OptiMesh. I do think it does have some advantages. Number one, it is you can do it through that same very small dilator, so 6 millimeters, so you don't need a big space. And for people that have, more advanced pathology and so on, it will actually conform to their anatomy. But when I went to Duke, I had Rob Isaacs there, and he said, listen, man, you got to design a traditional expandable titanium cage to go through Kambin's triangle. I took that on as a project. And so that's what we kind of did. So, it's really important to understand that even once you've got into Kambin's triangle, you've done the discectomy and so on, you can't ignore that exiting nerve root. I think Dr. Jesus talked about this a lot. If you have a person that has a DRG syndrome, it's the worst patient ever. They call your office 6 times a day for 6 weeks. Miserable, right? So this is something that was really important. So there are people that talk about getting into Kambin's triangle and then just putting a K-wire down there and hammering a big cage. I would not advise anybody to do that because you put the DRG right under danger there. So what we did is actually made an insulated device that is encapsulated by all 3 dimensions so that you can put this in there and protect that exiting nerve root. Another advantage that I found kind of luckily is that these things kind of work as shims. So for those people that do laterals, it actually protects the end plate there so it doesn't allow for subsidence. So we published this, and I think it's really important for us to publish these results and look at them. So we published our first 1-year results. Our final implant looks like anybody else's implant. We have a expandable cage. Everything looks the same. We just did it completely percutaneously. So, for the first year that we did this, we had 16 patients. But I think one of the things that you want to look at is our blood loss was less than 50 cc's, right? This has now become a percutaneous surgery. There's not a lot of setup time and so on. So now I can start talking to my anesthesiologist. Hey, can we do these surgeries under spinal anesthesia rather than put them to sleep? This is our 2-year outcomes. We have now 50 patients, and we're looking at things such as lumbar lordosis. We're keeping the lumbar lordosis increased through 2 years. We're keeping our spinal pelvic parameters robust. I think this is really important. We looked at ODI and VAS, and we looked at fusion rates as well. It's about 92%. And I think also, as Dr. Pimenta said, we want to look at things as adjacent segment disease. So we're studying this, right? We have about 3% per year. So it's about average to all the fusion methods that we have. So that's one thing that we've done, and we're going to compare hopefully the OptiMesh to this expandable titanium cage that we put through Kambin's triangle. We've used the robot actually to enter into Kambin's triangle. So for the residents and the fellows, you can learn to do a little bit of trickery and so on. So we just designed a screw to go through Kambin's triangle. And this was our first case that we did. It was a patient that refused general anesthesia. We put them under spinal anesthesia. And you can see here we use the robot to enter into Kambin's triangle. We put the cage in there. This is the blood loss from that case. Patient, did very, very well. We've now published a case series on this, and patients are doing very well for this as well. If you use, CT and anatomy, you're ignoring the nerves, and the nerves are so important. So I actually went into neurosurgery to be a functional neurosurgeon. So I was really interested in nerves and pathways and so on. So we actually used, and I think Dr. Hartle is maybe doing some of this as well. So we used the Brain Lab software to actually manually segment out the nerves at each level. And we actually do a lot of preoperative planning from this. So we can now know exactly the dimensions of Kambin's triangle before we go into surgery. So I know, hey, if this person doesn't have a radiculopathy, I can go on the side that's bigger, right? And so I can measure that before I go to surgery. This is really cool. I actually could find out that the person had a conjoined nerve root before I went to surgery. So this is, I think something that makes surgery much, much safer as well. Not surprisingly, this paper just came out in World Neurosurgery. If you take the nerve into consideration, your area for Kambin's triangle will get smaller, so you have to worry about DRG syndromes and so on. And just because you have a hammer, even though it's a very small hammer, doesn't mean that every patient is going to be appropriate for this. So we saw here, this is a case, we measured here, the biggest diameter that we could enter into Kambin's triangle was only 6 millimeters. That's going to be too small for any type of implant that we have, right? So now that takes us to the next level that we're doing. And now we're segmenting not just the nerves, but the bones as well. And we're doing what we call virtual surgery. So we go in here before surgery, say, okay, if I take off the SAP, if I take off the IAP, what kind of corridor do we have? So now no longer, Dr. Hartle, do I worry about that external nerve root? I actually know exactly where it's going to be before surgery. So then this is a paper that just got accepted into operative neurosurgery. We found that you can measure the pathways from the transfacet through Kambin's triangle and through our, traditional T-lift corridor. And we can then measure preoperatively, what dimension of cages we can put in at each level. So this is a case, a 36-year-old gentleman, grade 2 spondy. He's not a good candidate for O-lift, not a good candidate for A-lift. And Dr. Pimenta could do a lateral, but I can't. So this is a surgery that we're going to do this transfacet pathway. So we segment out all these things. We put in the screws using this instrument tracking. Then we merge the preoperative CT to the preoperative MRI. So then I know the exact trajectory to go in to do my transfacet T-lift. And we actually have this heads-up display after I've docked and doing my facetectomy. I can know where the exiting nerve root is. I can know where the traversing nerve root is even before I get there. And then we talked about these different implants. I'm not going to talk about the commercial methods, but this is an implant that both expands up and down and medial laterally. So you can see this looks like a lateral or even an A-lift type implant that we put in through the transfacet pathway. So I think that this really talks about needing to do these patient-specific T-lifts. So now when a patient comes into my office and I think I want to do a T-lift, I'm measuring out all these different areas, all these different angles, and I'm trying to figure out what is the safest way to do this surgery, right? So it's no longer I'm going to figure it out in the operating room. I'm going to figure this out even before I go to the operating room. And that's what we used to do as neurosurgeons. If we had a brain tumor, there's no way we would say, oh, we'll just figure it out in the operating room. We know all these planning and so on, and that's what we're doing all the time. So I only have 1 minute to talk, so I'm not going to get into all this other stuff. I think endoscopy is also, a very important thing, and I got a little bit into endoscopy as well. And then you can do a lot of these surgeries. If I show you, if you're not losing a lot of blood, you can do them under spinal anesthesia. Once you prove to the anesthesiologist that you're not losing a lot of blood, you can get these surgeries done really well. If you're at the ASC, I can do a 1 or level 2 level TLIF and have the patient go home within 24 hours. So with that, I'll close up. Thank you so much.
Yeah, Mohammed, it was quite interesting and remarkable. Congratulations to, you've published a lot and done really a lot of really fascinating work. I'm sure we'll have a nice discussion. Christoph, you get started.
Hey, I really loved your data that you showed there, so congratulations on that. My question was for you is, I have a hard time to make the decision, to decide when to do an MIS TLIF and an endoscopic fusion, and I typically err more on the MIS TLIF because I can get a bigger cage in there. Now, in your program, which is really awesome, how much can you plan in on the mobility? Often you can reduce the disc height. Often you can, remove some of the SAP if you come from transforaminal. How much can you calculate in there? I mean, do you anticipate that, or is it right now static?
Right now it's static, but I think that's the next step, right? So and we do this a little bit, but we want to take it to the next level. Actually, what I really want to do is have this all automated. So right now I have, a very eager medical student that, measures out all the nerves and so on manually. But we're building the data set to do a deep learning way to actually have this all automated. So I'd like, hopefully by next year, come to you guys to say that now anybody that comes in with the, clinical MRI, we have all this stuff done automatically. And then I think to the next step, I think Dr. Pimenta, we've talked about this a little bit, is, talking about lateral surgery. Can we know where the plexus is before surgery, and can we predict where it's going to be? Because I think this, patient-specific surgery is very important.
Yes, Frank.
Yeah, really great presentation and phenomenal how rigorously you're studying this and doing this. So 2 questions, one a technical, one a philosophical, I guess. The issue I've always had with endoscopic is you can get cages in because we have sexy cages now, but it's always the disc prep and the end plate prep. And, I do a lot of TLIFs despite lateral. And like Roger, the longest part of a TLIF is you mentioned is the disc prep, right? And I've seen all the brushes and the stuff, for the endoscopic. It's very hard. I mean, you said high fusion rates. I'm not sure I buy that, but how do you prepare the end plates down those small cannula if you do it sort of endoscopically? I mean, you scrape a bit. I remember a couple of years ago, one of the companies brought in, we did a lab, and after about 2 seconds, I pulled out a big piece of disc, and they had their world expert there. He goes, "That's amazing. You're ready to put the cage in. That's the biggest piece of disc I've ever seen come out." Not true story. So how do you prepare the discs? And then the transfer set, just explain technically where you actually dock and how you do that.
Perfect. So for the first question, I think it's a really important point. I think that just using the brushes and so on is not going to be enough. I think now, and we'll show it in the lab, we can actually now get an endoscope down into the disc itself, and under direct visualization, look how much disc prep we've done.
I get that, but what are you using down the cannula is my question. You can see it for sure with an endoscope, but what are you using?
There's different instruments that are brand now. One of the ones, I'm not going to talk about the company, but there's one actually that articulates all the way back, because the hardest part actually is the ipsilateral higher corner, and how you get that. And so there are now newer instruments that allow you to do that. And there's some very good work done with cadavers and stuff to show, how much disc, prep that you can do. So I think you cannot waste time with that. You cannot cut corners with that. I think it's really important to, spend the time and do that. And there are the newer instruments that allow you to do that. In terms of the transfacet pathway, so if you use the SAP and the IAP kind of as your guide. Basically, if you drill down that corridor and you keep the joint as your middle point, you can actually enter into the disc without actually seeing the nerves. So there's a matter of philosophy.
Sorry,
right?
not to interrupt, but so you dock on the facet.
You dock on the facet. And it is a matter of philosophy, right? So I had two surgeons that I trained with, Dr. Groff and Dr. Chi. Dr. Groff would say, if you're looking for something dangerous, find that thing, protect it, and then do your surgery. That's one philosophy, and that's kind of an older philosophy. The younger philosophy is, if I don't see what's dangerous, then I can keep going. And so that's what we basically doing, right? And that's what we do. That's what we do with brain surgery now, right? So if there's tumors, we don't do positive mapping. We do negative mapping. If I don't find, Broca's area, I'm going to take out this tumor.
Yeah, very, very good talk. Congratulations. I'm surprised to hear from you this, as you have a huge experience in PTP as well. But can you explain me, you do all this effort, it's like going to a room through the window instead of the door, right? When you decide to do, when is a good indication going through that small approach versus so much in the front first?
You sound like Trump. Didn't he talk about going through the window versus the door?
Second is how you can do awake surgery so close to the DRH, the nerve, right?
So the first question, I would politely disagree, right? So our patients, they deserve this, right? They deserve that we look under things very meticulously, right? If we had a brain tumor patient, we would never say, you know what, I'm just going to figure this out when I'm there, right? And so you can see, with this thing with the conjoined nerve root, if you don't know there's a conjoined nerve root, and actually this came from Dr. Friedman, he said, well, how do you know that Kambin's triangle actually exists, right? Because if somebody has a conjoined nerve root, Kambin's triangle is going to be very, very small, and you're going to hurt that patient, worse than a DRG. If you did that surgery on a conjoined nerve root, you're going to give them a palsy, right? And so I would disagree with you. I think that our patients deserve this type of meticulous understanding, and I think we should do that even for the laterals, right? We need to get to that point where we know exactly where things are. We can predict our complications. We can predict what the safest way is for surgery. So I would disagree. I think if we have to jump through the window, I'll jump through the window. Forgot the second question. I'm sorry.
No, but awake surgery.
So actually, awake surgery, and I didn't get a chance to get to it. There's two types. There's one where you do a spinal, where you can't, and this comes a little bit to neurosurgery as well. So if somebody has a spinal, you can't monitor their DRG, but you can actually do monitoring. So I actually do monitoring for my spinals. For my endoscopic cases, you can actually do it just under local, and if you come close to the DRG, they'll tell you. And so actually the patients work as their best monitor. So actually awake surgery is perfect for those situations.
Have you heard of MRI neurography?
I have, and I've talked to Kelly about it. Right now, it's not getting us quite as lateral as we need to. So this is something that we need to think about.
Conjoint nerve roots, obviously you always look for those. You don't need brain lab or, any kind of fancy software. You can see it on a regular MRI scan, and it's important to make sure that, that's not there if you do any kind of surgery there. But I think what you're showing is really the future, right? It's auto segmentation, artificial intelligence, and it's really it's amazing work. The question I have, doing a fair number of E-lift surgeries myself, I do sometimes a lot of bony work to really maximize the size of Kambin's triangle. And if you do that percutaneously, though, that seems to me very tricky. And also, I like to see the nerve because I really want to, it's maybe old school, but I want to really make sure the nerve is there. I actually stimulate the nerve, and I sometimes retract it because that's the worst case scenario, that you bang into the nerve. How do you avoid that percutaneously, and how can you maximize your window percutaneously?
Yeah, I think those are really good questions. And I think that right now the technology just isn't there to do those things. And so I've actually, I came in doing a lot of Kambin's triangle and so on. I've actually moved a little bit more towards the transfacet because I feel that that's safer. We showed that the area is larger. And then I can also, as you've shown, then I can, if I need to do a direct decompression, I can wand over and do an over-the-top decompression. So it gives me more versatility.
So you take more of the lateral facet
Yep.
as you kind of, yeah. All right, any other questions? Well, Mohammed, thank you so much. That was great. And we'll